and quite excited and happy to be here as usual. Sir,
Patients, I told them they had to come here to get to know you.
got it. That it does work the best that way. And I'm sorry that I skipped 1 or 2 months in the summer. I was playing hooky, and but I'm back and happy and excited for the rest of the year to be around, hopefully every month. So, anyway, I put together about 10 or 15 slides just to kind of spark a conversation, as usually, not meant to be a full lecture for the whole hour. And I try usually in this time of work, I use something that's been in the news recently to spark a conversation and try to link it up to some of the work that we're doing, some of the research work we're doing. So it's not really a lecture, it's just kind of a bunch of thoughts patched together on some slides. And so interrupt me, please. Give me an opportunity to fill in the gaps as I move along through these slides. But so I thought I'll talk to you about the brain-heart vasculature connections. This is kind of a new topic, if you could imagine, in medicine. It's kind of understanding that or learning that the heart and your brain are connected in some way, probably connected because of the vasculature. So that's kind of in between the two, but maybe other components may be influencing that as well. So it's just making you aware of this connection, because I think in the next decade or so, we're going to talk a lot more about this. And you can start talking about this with your doctors when you go and visit them. So I'm going to start by a research project that we're doing at UC Davis. And the research project, we're able to do this research because UC Davis, about 8 years ago, got a very, very large grant from the NIH that allowed them to build a brand new PET scan. A PET scanner is a nuclear device. Well, it's a nuclear camera that allows the doctors to give you a tracer with nuclear activity, and the camera can measure the positron emission tomography. That's where PET comes from. And it's able to look and see, it's a molecular tracer, what we give you. So it sees the organ that picks up the chemical that we give you in the IV. And so it allows us to see the activity of that organ. It's in contrast to a CT scan, which you're probably very familiar to. It's mostly an anatomical picture. It's a picture of the organ's shape and structure itself, but not the function of it. PET scan, on the other hand, it's usually a chemical that interacts with the organ, and it gives us some sense of the function of the organ. So it's a lot of times complementary to a CAT scan. So in the picture on the top here, it shows what a normal PET scan usually is. You lay on the table, and then there's a camera that goes around you, and these little blue coils here is the actual sensors, and it just measures a little portion of your body, and then it shifts up and measures another portion of your body, and then shifts up and measures another portion of your body. It's like a stitch quilt, and for about 18 to 24 centimeter pictures at a time. And so what UC Davis did is build this one down here, where you don't have to have a camera that move up, because you now have the camera spans 1.9 meters length. So most of us will fit from head to toe inside of the camera. And then you can take a picture of the entire body all at once. You don't have to have a picture and then move over, a picture, move over, a picture, move over, which is what everyone else does in the world. Now at UC Davis, we can just get you in the tube and take a picture, a single picture all at once of your entire body. There's a lot of benefit to that. I put a couple of them here. It can capture what we call high resolution 3D imaging, and it is actually true 3D imaging. A lot of 3D imaging out there is kind of model 3D. It's not an actual true 3D. So that's real 3D picture. It can give us in a single scan all the organs in your body at the same time. And then because of the way it was built, we can use less radiation on the tracer. We end up with higher resolution, so we can see a little bit more clear your organs. There's a joke in the nuclear medicine world. So if it's your friend, tell the joke. If it's a nuclear medicine doctor, if it's not your friend, they'll get upset with you. we joke about it. We said it's not so clear medicine because the pictures are not very clear. They're very fuzzy and not very clear. But now with this new resolution, we actually can see the structures of the body much easier, much better because of the higher resolution. So I'm going to prove that to you. There's a picture, a movie that's going to show up here. This is the IV coming into the arm of a person, and it is black because the tracer is in there. And the tracer is it's like a sugar molecule that's been linked to the radiation compound, so we can see with the camera where it goes. And so you're going to follow over 30 seconds. You're going to follow where this tracer goes. We're going to do the movie twice, and then I'll stop it to show you the organs and see how well they look. So I'll let you see how we see it in the dynamic scan. We call it the dynamic scan because it's moving around. So ready for a movie? So this is real time. This is the time it takes for the tracer to go in the arm, and then it goes around and it's circling around your body and being picked up by every organ on your body. And I'm going to stop it this time. Right about there. So give you an anatomy class. On the top, very top, dark cauliflower up on the top is your brain. Down, trickle down on the bottom is your toes, way down here. You get them all in one picture, per second. We get a scan per second. And in the center, where all this stuff is in the middle, you can see the heart. This is the heart, kind of on the center to the left. Right below it, this dark structure here is the liver on the right, and down to the left is the stomach and the spleen in here. The two little kidney beans in the middle, with a few dark spots in it. That's your two kidneys. And then the two little tubing things coming out of the kidney is your ureters going into the bladder. And this dark spot down here in the mid portion is the bladder collecting urine. And so this tracer goes in the blood, travels throughout the body. The kidney starts filtrating it and put it in your urine. And then when you go and pee, you get rid of the tracer in your body. Like I said, it's a sugar molecule, so it's like it gets handled like sugar, and then you pee it out. You can also see down into the legs. These are the arteries to the legs. So you can see that we can see blood flow, and whether your arteries down into the legs are open at the same time that we can see the arteries into your brain are open and the arteries to your arms are open. So it just gives an opportunity for the first time actually ever in the history of the world to take pictures of your entire body per second and follow the blood flow all around. We're no longer the only ones. There's about over 15 centers now in the US that have one of these. And there's probably about 20 or 30 centers around the world that now have one of these. So there's a competition now, a race to who's going to get the best knowledge out of this over time. I'm sorry?
Does Medicare cover it?
Yeah, so that's a great question. So these scans are actually clinical scans. So yes, they're using these at UC Davis for cancer patients and others. But it's a regular clinical scan. We're using it for research. So we're doing all the fun, fancy stuff. They're using this amazing tool to take straightforward clinical pictures, which you can get done in another scan. We're already using it at UC Davis for clinical practice. But it has so much more potential for us to do studies like I want to chat a little bit about today. It's the connection of the brain to your heart and to your vasculature. And so we can look at that in a single patient and start asking questions about what happens to your body when ... when something is like an illness or an event or a heart attack or something. And we can then evaluate all the organs in the body. So because we have this ability now, we can start thinking from a scientific point of view of questions we want to ask and things we want to learn about the interactions of the different organs of the body. And so that's what I want to start chatting with you, is show you some of the work we've done on that and kind of where that is leading us. Any questions about this? That's kind of the technique. So using this technique now, we've done some studies on looking at patients who've had heart attacks. So you come to the hospital, have a heart attack, the doctors go in to do a cardiac angiogram to find if an artery is blocked. And remember, a heart attack means that one of your small arteries to your heart is blocked, usually from a clot. And then if we find that artery, we're able to put usually a little wire in it, poke a hole in the clot, and then go in there and put a stent and open it up. And you walk away, go home the next day with an open artery. so that the heart is able to then reperfuse the muscle, and then your muscle survives. And the better the muscle survives, the better you feel 3-6 months later, because you recover from that, and no scar forms in your heart. That's the whole process that we'll want to do when you have a heart attack. So we wanted to know, how do the other organs in the body get affected when you have a heart attack? Because we think of a heart attack as just something happens to your heart, but does it affect all the other organs in your body? That's the research question we have. And so this is the first study we did, looking at 10 patients who just had a heart attack, and 10 days later, after having a heart attack, they come back to the center to do the PET scan. And we compared it to 15 patients who did not have any heart attacks. They're healthy. They're not even patients, they're healthy controls. So people who are agreed to do this while they feel well and don't have medical problems. So we can have a comparator group to the people with a heart attack. That's how this design it is. We use the FDG, which is the sugar or glucose analog for this. And then we looked at all the organs, and we hypothesized, or we believe that what happens when you have a heart attack is that your entire body gets inflamed. So it's inflammation all throughout your body. And so we were looking for inflammation. FDG, or the tracer, is usually picked up by the cells in your body that are called the inflammatory cells, or the cells that go around putting out the fires of inflammation, if you will. And so if there's a high concentration of these cells in any one organ, then the FDG will accumulate, and then it lights up, like you saw the bladder, for example, on the first movie, where there's accumulation of that tracer in there. So it lights up like a dark spot. So we look for the dark spots in the organs to look for what is involved with a heart attack. And so Dr. Racina, our fellow who was doing this, looked at several organs, because again, we thought it was inflammation. So we look at what we think are the inflammatory organs, the organs in your body that are responsible. And we were surprised about how much lymph nodes were in people's body that light up with after a heart attack. So he actually characterized all the lymph nodes. So he has here head and neck lymph nodes in the right, head and neck lymph nodes on the left, the axilla right and left, the inguinal, which is the ones in the groin. So he looked at all the different lymph nodes, and then he looked at the bone marrow and the spleen. And it's kind of hard to see from the back, but these numbers here is the average for all the 10 patients in the values of the intensity of the signal from the marker for inflammation. And all of them are statistically significantly higher than the control. So essentially every one of these organs get inflamed, essentially, when you have a heart attack. So it's not just inflammation in the heart. This inflammation happens on all the lymph nodes and bone marrow and spleen. So it is a systemic condition. And we've said this before. We said this for decades. We said heart attacks are systemic conditions. This is just a proof of evidence that your entire body is affected when you're having a heart attack. For those of you that like anatomy, and this is very challenging because this is a bad picture, but this is just a zoom. This is the neck here, or just below the neck, and this is the head. And so again, the big dark cauliflower on the top is the brain. And this is a normal patient, and this is a patient with a heart attack. It's hard to see from the back, but the arms of this person are over the head. So they're like this, with their arms like this. So what you're seeing here is the armpit. The lymph nodes on the armpit, there's 3 or 4 on there. There's 3 or 4 on the other side. And there are lymph nodes on the neck. This is the thyroid right here. And it's the lymph nodes on the neck. So we got a call from the radiologist about this. Oh my God, your patient had a heart attack and now may have lymphoma. Call the cancer doctor to find out about their lymphoma. And it's like, okay, great, thank you. We'll talk to the patient. Then we got the second patient, they call us again. The next patient has lymphoma. And we got the third one, and they go, we need to write this up. There's an epidemic in Sacramento of heart attacks and lymphoma. And we said, calm down, it's not lymphoma. It's that the body is inflamed and all the lymph nodes, just like it would look like if you had lymphoma. And your doctor sends you for a PET scan, which they usually do. And then they look for FDG accumulation on the lymph nodes. And when they see it, they say, cancer in the lymph nodes. This is not cancer in the lymph nodes. This is inflammation in the body because of a heart attack. So that's, when now we have the ability to start looking at all parts of the body, and we're going to learn a lot about these interactions, and we're going to have a lot of radiologists calling us panicking about these things because they haven't been seen before. So This is the same patient down further down into the pelvis. So this is now the pelvis down here. And again, pelvis of the normal, that's the bladder right here, which I show you on the movie. And so there are no dots on the sides here and there are dots here. These are the lymph nodes on the groin as well. So it's just showing there's lymph nodes everywhere. So this is to say that now we have the ability to look at the entire body, look at the different organs. In this project, we found the spleen, the bone marrow, and all the lymph nodes in the body to be activated during the heart attack. And so we interpret that as the inflammation that is occurring during the heart attack. Excuse me. Yes. Yeah, excellent question. We treat them with the medications that we usually do for after the heart attack, and some of them have anti-inflammatory effect. For example, the statin that you take has an anti-inflammatory effect. Some of the blood pressure medicines have anti-inflammatory effect. And then it's the exercise and the quit smoking and the eat healthy, which actually takes care of the inflammation. So the doctor takes care of the artery that's occluded. What takes care of the inflammation on the rest of the body is the combination of medicines and healthy lifestyles. And that's kind of at the end, the point here, that the healthy lifestyle is not only just benefiting the heart, it's benefiting the entire body. Entire thing is getting better by doing this because there's a general inflammation across the entire body. Okay. Excellent question. Now, this gets a lot harder. This is for those of you who wanted more punishment from anatomy. So this is a PET scan again, one of our PET scans. And I'm going to orient you again. The cauliflower is out of the picture here in the top. Be the brain. This dark spot here is the heart. So that's the heart sitting like this in the chest. The center is the spine. You see a spinal bone right here. This here's the liver, which I showed you in the movie earlier. Down here's the spleen and stomach. The kidneys are sitting somewhere in here. Now there's these very, very flashy colors. What this is, we have now computer software that allows us to map out the aorta. This is the map of the aorta on this patient. So the heart is here, the aorta comes out through the aortic valve. It's a major vessel that comes out of your heart and distributes the blood flow everywhere in your body. And it has sections, so they're sectioned by number. And the importance about this is we know that the entire organ in everybody is not the same. So we now have the ability to find the same spot across individuals, and now we can compare it from spot or top out of the heart is in a different place on the picture. And so this allows the software to find the right, correct anatomical place that then we can compare. So we can then take 10 patients and look at section 4 for all 10 patients, and we know we're looking anatomically the same portion of the heart or the aorta. This is important for us to have validity on the results that we get. So just showing you how we get this done. So this is the same patient, but instead of being now this way, now they're sideways. And now you can see the spine on the back. And you see how the aorta comes out of the heart here. That's 4 and 4 is the same place. You see in the 3 pictures, we can actually identify the region in the picture that corresponds exactly to the same spot. But now they're changing angles. So that's 4, that's 5, that's the arch coming up. The section between here and here is out of this picture. But then you got 6, 7, and 8. This is now same person, but now cutting through this way, like a loaf of bread this way. You cut on the loaf of bread like that, and then you turn the loaf of bread, and now you're looking down the dough of the bread. And that's the heart. And that's where section 6 is here, but not seen here. So this allows us in 3 different views to find the same spot in a person and be able to compare it to the next person, 3 different views. Allows us to do a very homogeneous comparison and be able to evaluate how inflamed is the aorta. The aorta is the vasculature now. I already showed you the lymph nodes and the lymphoid tissue. Now I'm going to show you the vasculature, and this is how we collect that. And so this is the quantitative data. So this is, again, my same 10 patients that I show you on the first poster with a heart attack. This is looking at the level of inflammation of the FTG signal, if you will, in the aorta for those patients. And it shouldn't be hard to see that it's higher with the heart attack patients than it is from the purple people over here on the right. These are the healthy controls. Remarkably different. In fact, there's actually almost no overlap between them, even though there's a variation within the group. And then these people in the middle is a collaborator of mine who's interested in arthritis. So these are different kinds of arthritis. And so there's some people in arthritis that are like the normals, and some people with arthritis that are a little bit like the people with heart attacks. And that kind of adds to the concept that arthritis is an inflammatory condition. Some arthritis, this is, I think, rheumatoid, and this is psoriatic arthritis. Yes.
What's the time frame for the gut inflammation and how you get to a point where you can then identify maybe it is cancer, maybe it is.
That's a great point. So we do a follow. So within a month or two after treatments, we expect that all this inflammation comes down. And then if we're concerned that it's cancer, then we go back probably about 3 months later and rescan the person. So if all the other markers of inflammation has come back to normal, you're exercising, you're eating healthy, you're taking all your medicine, and all your lymph nodes are still lighting up, then at that point, we may need to have a needle put in to make sure that it's not a cancer. Great question. So this shows that we now can look at the vasculature and see the big difference between the heart attack patient and the normal, and then some intermediate patients with different conditions that are known to be inflammatory have kind of an intermediate amount of inflammation. So once again, the same person, same scan. We got the lymph nodes, the bone marrow, the spleen, the aorta. And currently we're working on doing their brains. We haven't got the brain portion of this done yet, but we're currently looking at the brain and the heart, actually. Turns out the brain, as you saw, is a big dark cauliflower. It's a lot of signal there. So it takes a lot of new algorithms and mathematics to figure out how to eliminate all the noise on top of it to try to get to some meaningful information. And as you would imagine, the heart is also complex because it's not only has a high signal like the brain, but it also moves. The movement creates a lot of fuzzy signal. So we have very smart mathematics and engineering people working right now to figure out how to get the information out of the brain data and how to get the information around the heart. So when I have that, I'll bring it back to you. But this is not the Lewy body. I mean, those are PET scans, but not the specific PET scan. The difference in PET scans is based on the tracer, by the way. It's not the machines. It's the tracer that the doctor injects on you. The different tracers bind to different things, and based on what they bind, then we can make a diagnosis for different conditions. So it's the tracer what makes the difference, not so much the camera. Although we have shown you, hopefully convinced you, we have the fanciest camera in town for doing this. But ultimately, the other doctors in other health systems can do these tests with the different tracers. So now, about a year or two ago, I made another presentation, which was not data we generated, but it was data generated in other center. I think it was in Boston. They looked at the actual brain using PET scan as well. And they show that if you have inflammation of the brain, you actually have worse cardiovascular events. If you have a heart attack, a worse heart attack. And they proposed that it was through a process of inflammation. And so I have this cartoon, which was the summary of that presentation. So I'm not going to present again that, but I'm going to show you in a cartoon form, their summary of their presentation, of their data. So here's the brain, and they looked at by PET scan, they look at the brain, this area called the amygdala. And they say the amygdala activation, which is when the FDG goes up, which is like if it's inflamed, when that's activated, that relates to having the bone marrow activated. That's bone picture here. And the bone marrow puts out a bunch of cells, usually B cells and T cells that float around, some macrophages. They're just fancy names for bone marrow cells that go into circulation, and they go to the blood vessel, and they see the blood vessel and now create inflammation on the blood vessel. So I just show you that we have pictures from the bone marrow, we have pictures from the aorta. We're missing right now the brain to be able to test this that they proposed. This is a proposal they made. We're trying to test this ourselves. And so that's kind of where our research is going with this, is be able to see, do we on the same, because they don't do this, they do this by looking at the stitch kind of scan. So they just take a picture of the brain, and then later to take a picture of the bone marrow, and later to take a picture of the vasculature. We're going to be able to take a picture of all of them all at once, which should be more convincing or not that all of this is happening on the same person at the same time in every organ. So that's what you would imagine it is happening. So if the brain is making the cells move to the vasculature, that all of this will be happening in the same body at the same time. And that's to be determined. We don't know that. And that's kind of where we're going with our experiments. So we're working on getting the brain portion of this to work in our hands. I'm sorry. But what they said was that when your amygdala, and I call it the fiery amygdala because in some of the pictures I had, it looks like a bright red fire. The fire amygdala and the arteries and the bone marrow are related to each other, which is what I've been saying. That's what they propose. And then the fire amygdala is related to high crime and low income. So this now comes to the question is, why is it that the brain gets activated? And so they propose that the brain gets activated from social stress. So you live in a stressful environment where there's high crime and low income and poverty and other things, then your brain gets activated, gets inflamed, and that it then turns on the inflammation, and it's inflammation what then turns on the vasculature problems and potentially the heart attack or the stroke. So they're proposing that it is the stressors that come from the top in this cartoon, and those stressors can be biological and non-biological stressors, and could be just like environmental stress. And that's what turns on all of this. So you hear a lot about social determinants of health. We think that this is where the social determinants of health come in to essentially stress our brains. And then from there, all this cascade happens downstream of it. So we're here in our research, we're trying to understand what are the stressors that turn this on. I still got to figure out how to look at this. But once we can look at the brain combination to these other two parts, we're going to be asking questions. What are the stressors up here that turn this on? Because as you could imagine, prevention lives up here. If I can prevent the stressors, your exposure to the stressors, maybe I can turn this off rather than give you some fancy drug right here that blocks these best cells or some fancy block of medicine here that impedes the blockage from happening. If we can pinpoint what is the stressor that turns this on, then we work in prevention up here. And that's the whole point of doing this research is what's a better preventive target for us. And so that's kind of why we're doing this. And I'm going to show you one of these targets. Yes.
I'm just wondering, does mental illness fit into that?
Yes, absolutely. Depression, it's been shown in depression, it's been shown in, I think it's schizophrenia. These people have higher events of cardiovascular events. Yes, absolutely. Yeah. Yes.
Medication could lower that.
Absolutely, yes. Yeah. And so that will be one of the, if we can identify, if we can connect these dots, then one of the potential interventions here will be meditation or mindfulness to try to turn off. Despite all the outside stressors and noise, you can inside in your mind maybe block that, fan off from that by using mindfulness or meditation. Yeah, absolutely. So I just described my research program for the next 10 years to you, by the way. I should be busy with that for the next 10 years. So this is right out of the news. This came out on August 27th, 2 days ago. This is a presentation that was made at the European Society of Cardiology. Their meetings going on over there. I think it's in London right now. And there were two papers that were presented there. And the article that talks about the two papers, they haven't been published yet on the journals. So I haven't reviewed the journal. This is how hot of the press this is. But this is a report of somebody who was at the meeting who reported two papers that were presented. And the title is Noisy Neighborhoods Might Raise Heart Attack Risk. Remember my cartoon, stressor on the top, pathway, brain, blood vessels, heart attack, downstream of that. So this is potentially just some findings related to what are those stressors? Noise. That's what they're calling. So let me kind of walk you through what they presented. So there were two studies. And what is noise for the studies? Is, well, the noise that happens with constructions, cars honking, crowd noise, lawnmowers, movers banging and wanking on the neighbor's house, that kind of stuff.
Not gunshots.
Not necessarily gunshots, but they are stressful too. So, it can all be a chronic source of stress in urban dwellers. So you live in a city, you walk around, you can get exposed to any one of these, but they all add up to a chronic exposure to noise. So it's not just a noise on one moment, boom, big something drops and you go, that's not going to give you a heart attack. But it is the kind of the chronic high level exposure over the average of 24 hours. And they can measure the decibels per 24-hour on the average, and that's what they use to estimate the risk of the heart attack. And what they found is that people with low levels of heart risk factors, these are not people with smoking and diabetes and obesity and all these other things. So people with a low risk. When they list examples like diabetes and smoking, were more likely to be admitted to the hospital with a heart attack if they happen to live in a noisy neighborhood. So the noise, average noise in the neighborhood was the predictor of people who are healthier otherwise having more heart attacks. So that's a new risk factor. You know, we talk about smoke here, but now we're talking about other things that on top of that. So this is people who don't have those risk factors. Are they still at risk? The answer is, based on this, yes. Where is that source of that risk? They're proposing that it's noise. Yes.
What about the noise of news?
I feel like that's a double-edged sword. That question here. There's noise and then there is noise. I'm sure all of it counts. So there are two elements of noise. There's noise as it goes into your ears and it activates the brain without you having any judgments. I'll call that judgment perception. And there's noise you get where you perceive as is stressor. So your family arguing, when they're arguing over something good for you, may not feel that that's perceived as that stressful, but you still get the noise portion of it. And then if they're arguing with you about something that you want to, they want to win you over and you don't want to give in to or something, that may be felt by you as stress. Same amount of noise, but now you perceive it as this is really stressful. You're making me upset. Why are we talking about this again? I thought we gave that up 10 years ago. Yeah, you know, those family arguments, right? That is now stressful. So now your perception of stress. And we think that both matter. There is the noise without the judgment, and then there's the judgment perception, and that's two separate layers of processing. So if you got the noise and the perception, you got the double one, versus if you got the noise but no perception. And I think that still needs to be teased out, the actual contribution of both of those, but I think both of them matter.
There's a particular noise that is in my neighborhood that is a product of the music.
Mm-hmm.
I don't hear any music, but I hear this boom,
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 mhm.
boom.
Yeah.
And it goes on and on and on. I don't know where it's coming from. It's not this neighbor, probably not that guy, but you can actually
Feel it. Yeah.
how it is affecting.
Mm-hmm.
And it's sometimes a car will pull up and you'll get that. Well, that's so much better than this other because they're gonna go down the road.
Mm-hmm.
This is something.
Persistent. Yeah. Yeah.
And
Yeah, I think that contributes to the chronic exposure of the noise. That's
Yeah.
chronic exposure of the noise. And you probably can tell me when you go out of town and go to a quiet park or something, and you don't have that, you kind of feel a little more
yeah,
relaxed.
I know the difference.
Yeah.
Disturbing.
Yeah. So we got to start asking questions. How do you do that? What do you do? How do you handle that? One, you buy the house of the neighbor making the noise. That's one way of handling it, right? And they buy them out.
It can travel so far. You
Yeah.
really.
Yeah, I mean, I think it's an open question of how do we manage this, and how each one of us handle that level. Okay.
Davis actually has noise laws, which I don't know whether they're enforced or not. But at least there's a mindset of
Neighbor
the.
policy.
It gives people,
laws against
yeah, it gives people
Facebook.
permission to go on your door. Hey, can you cut it out? You know, it's against the law. So, okay, so what else did they do? So they looked at, oh, by the way, this work was done in Europe. So then the second study looked at people who have survived a heart attack for at least 28 days. And then they looked at them for 1 year, see how well they did. And so they had 864 French people in this study. They tracked how they did in terms of whether they had they died from a heart condition, they re-hospitalized for heart failure, or they needed more stents, they had a stroke, or they had more chest pain. So look at all these things. And what they saw was, first of all, the average level of noise in their neighborhood was 56 decibels. I'm sure you all know what that means, so I won't labor it right now. But they look at that over a 24-hour period, and they saw that each patient, and they measure that at each patient's home. And that's how they measure now the risk. So they look at the outcomes on these people with heart attacks, and then they look at the noise, they measure the noise in their homes. So this is not just an estimation, it's actually measurement of the noise, and then they calculate the average exposure per 24 hours. So since I'm sure somebody doesn't know what that means, here's a description of what decibels are, and gets a little bit to the noise question you were asking. So leaves, rustling, soft music, whisper, about 30 decibels. Average home noise is about 40. Normal conversation, background music, about 50 decibels. 58 is right here between 50 and 60. That was the average for the study that they found on the people in the study. 60s office noise inside a car at 60 miles per hour. Depends what car it is. I don't know that they tested a Tesla or something that doesn't have an engine, like a fuel engine, but anyway. Vacuum cleaner, average radio is 70. And then heavy traffic, window air conditioner, noise restaurant, power lawn mower. That's 80, 89. This is kind of where the World Health Organization puts the cutoff for unhealthy. So they say noise higher than that is unhealthy. And they even make an estimation that because of noise higher than the 85 decibels, because of that, there's an estimate of 1 million healthy years of life lost every year due to just noise in the world. So it's a big number, it's a big world, and a big number of lives lost because of noise alone. That's the estimation from the World Health Organization. So subway, shouted conversations, probably family arguments, school dance with music, boombox. Boom, boom, boom. So 90 to 100. Chainsaw, snow blower, stock car races, gunshots, here it is, sirens at 100 feet away from you. So it gives you a sense of that. But these are like very sporadic. It's like you hear the siren for 20 seconds and it goes away. This is average. The unhealthiness I was measuring in this study is the average exposure to this noise for 24 hours. So if you're hearing car race the last 24 hours, then you were getting 130 decibels all day long. So you just got to put it in perspective. It's not just hearing that once in the day that gives you the risk. It's really an average of everything you heard throughout the day. Yes.
Two things. One is the typo.
There's typos. Yeah, I know. I saw it. I noted it too.
How do you shoot down?
Yeah, no, I know. I actually, we'll get to that. We'll get to where this came from a little later.
The other is that if I were comparing, I would also look at people who are hypersensitive, like autistic.
Mhm. Yeah.
It's a similar
Yep.
response to the noise.
Mhm. Yep.
How about people who are deaf?
Or it's the same thing.
Right, right.
So, and on the other end, people in war zone where there
Right.
is a background, both noise and the mental stress noise,
Mhm.
and separating heart attack from explosion.
Right.
Stuff. But it would seem to me that those are the logical stress populations that down the road you would say, okay, and look at those post-war places.
Mhm. Mhm.
What
Yep.
is your incidence for this?
Yeah, and absolutely. I mean, veterans have much higher rates of not only stressful conditions, like mental conditions, but also cardiovascular conditions. And so that may be another. So if you're in combat and you're hearing this through days to weeks to months, that is clearly a risk, an additional risk factor you have over somebody who was three miles behind wherever the combat was and was only hearing this. So just have a difference of exposure to risk. So absolutely. And the epidemiology supports what you're saying, that exposure to these areas, these kind of environments are already known to be associated with increased disease risk. So
as opposed to that.
Yep. Yeah. A lot of people, the effect of that in the moment it happens, and then afterwards can get triggered by noise to then have relive episodes of stress by the noises that they get exposed later on. And there are people who have genetic variations where any noise is just very disturbing to them. If you live with somebody who every time you chew a grape complains about how loud you're chewing, you've got to wonder, and no one else hears it, you got to wonder whether they have a mutation and they're just hypersensitive. So they probably more disturbed about everyday noise down here than the average others. So there's a lot of variation. So this is at this level of research, this is all population level research. So we average the people, we average the noise, look at the average people and the average noise. It's not quite precision medicine, which is the individual, you as an individual, how this individual exposure affects you. That's more of a precision medicine component. It's more kind of like average group component. Okay. So overall, what they found was that heart attack survivors' odds for some form of cardiovascular event jumped by 25% for every 10 decibels rise from 58. So if your average noise exposure was 68, you have 25% more at nighttime noise level. It's rise in nighttime noise level. It's a specific one they look at. And so this did not, so usually when you do the studies, you look at other things that could explain that and you try to analyze it in the statistics to see if their contribution, see if this essentially washes out when you control for other things. And the findings stay true even after they factor other environmental stressors like air pollution and poverty. Remember I mentioned poverty earlier. All the things that we know are stressful. They control for the pollution and poverty in the area where the noise was happening. And even after they control for that, this still existed. So it suggests that it is truly the noise, that is not other things associated with noise. So there's two studies together were presented at this meeting. I already told you about that. So remember, it's considered preliminary research until it's published in a peer-reviewed journal where people have actually had a chance to analyze every detail of the study and make sure things were done properly and there were no flukes and things. So it's just an early report of something that fits well the bill of what we were talking about. What are the stressors that then feed into the inflammation of the heart, the brain, and the vasculature? So if you're really interested on this topic, I already went over the takeaways. If you're really interested in this topic, we can share this link. This is actually an article at UC Davis that was from 2023, where the heading is "Cool Everyday Noise. Could everyday noise be affecting your health?" And it has a list of all these different health impacts that noise may have, not just heart attacks, in it. And we can share by email the link with you. But I thought it was a good summary article if somebody's really interested in more details about that. That's where I got that picture of the decibels. And there was no source to the picture in the article. So I couldn't give you the source. It was just in there in this article. So that's the link to the article, which was published in a website for UC Davis website. So somebody from the environmental department or somebody put an article together for the community on the effect of noise. Yeah. Any questions? Okay, I'm going to end really quickly with just, this idea that your brain and your heart are connected. It's kind of, and I mentioned at the beginning, it's going to become kind of a topic of medicine, if you will, conversations to have with your doctor and conditions in the future. And so this just came out in 2024, just the American Heart Association is recognizing, putting a spotlight, if you will, on neurocardiology. That's going to be the fancy term for the area. And it's the emerging field gaining traction among neurologists and cardiologists. So it's like where cardiologists and neurologists kind of have an invested interest in your care and your well-being. And so I just wanted to show you that there's a lot in here. This is a table that just shows the connection of things. So atrial fibrillation has been related to stroke, dementia, and migraines. Things that dementia, ischemic heart disease is related to stroke and dementia. Patent foramen valley, which is a normal variation of having a small little hole open in your heart, it's been associated with some stroke and migraine, very controversial, very not for prime time conversation condition. So sudden cardiac death. So if you have epilepsy or stroke, the direction of this relationship is going from, if you have epilepsy stroke, it's a greater risk for sudden cardiac death. Takotsubo cardiomyopathy, which is a stress cardiomyopathy related to stroke. So stress cardiomyopathy, stroke relationship. Valvular heart disease, we've been known for a long time, relates to stroke. So we give you blood thinners when you have valvular disease to prevent stroke. Same thing in atrial fibrillation. We give you blood thinners to prevent that stroke there. And then certain cardiovascular procedures can be associated with stroke and dementia. So this is a place where the cardiologist and the neurologist come together, caring for your brain and your heart at the same time. So there's a lot more attention to this relationship. There's going to be a lot more research coming up about how these things one affects the other. And we're hoping that our PET scans techniques are up and running soon so we can start not only contributing to this part, but also trying to explore the impact of stress on the upstream of the impact to the brain, the heart, and the vasculature. And with that, I'll end by saying the brain-heart vascular connections are a new frontier for prevention. So as we learn more about this, we'll hear over the next decade or two more about how to work on this aspect of prevention. Thank you. Yeah. This one? Yeah, great question. There's a level of the condition that got you the procedure is probably contributing. That's what the ones above are. But then if you go and have a procedure, there could be an influence of the procedure itself on top of that. So it's one of the risks that we declare and quote people when we're going to do, for example, a cardiac angiogram. If we're doing just a diagnostic angiogram, the risk of stroke is nil. Can it happen? Yes. Have I seen one or two over a decade? Yes, but they're very nil. The moment we start doing interventions where we're starting to put stents up, the catheters get a little bigger, they get a little stiff. It's a small increase, which is directly related to the procedure itself, not just the condition. So there's some element of procedures that could actually precipitate, as you can imagine, these wires and catheters have to go up and around the aorta, which I show you makes a turn. And when he does that, if you have a lot of plaque, cholesterol plaque build up in there, more often than not, there could be some that break loose. And so that probably happens very often, but doesn't translate into a stroke. And there's a very few number of people that still converts into a stroke. So I think that's what they mean by these procedures. The dementia question here is a little unclear to me what it exactly means, but I not only I know, I see, and I understand the connection between the procedure and the stroke. Not the most common thing, but it is real. So, yeah. Anyone else? All right. Anybody at home?
There's a question.
Oh, yes. Yeah. So to answer your question, I'm going to ask a question from the group. Just shout out what you think is the most common cause, not the name, but the cause of dementia in the United States. Inflammation, plaque. You've always been very thoughtful about this. Isolation, psychiatric disorders, hypertension. You're a very interesting group. I usually get Alzheimer's, and old age and Alzheimer's is what I get out of that. Yeah. So it's actually called vascular dementia. So it is the effect of the vasculature in the brain. So small vessel blockages, they usually happen with cholesterol and high blood pressure and aging together. Diabetes contributes. So what I just said is all the cardiac risk factors, right? So the same risk factors for this vascular dementia are the same as as heart disease. Put that in one hand. On the other hand, let's look about atrial fibrillation. What are the causes of atrial fibrillation? Very rarely is genetics. Very rarely. Most of the time is acquired. There's a lot of it as structural. So if your heart, for whatever reason, gets enlarged or has high pressures or something, the structure of your heart gets changed, then you get atrial fibrillation. But the other main reason is high blood pressure, diabetes, smoking, aging, which are the same risk factors for stroke, which are the same risk factors for dementia. So at the end, when you start looking in the details, most of the conditions we deal with in general are the result of the way we live. It's the result of whether we have high blood pressure, dementia, diabetes, smoke, noise, the food we eat with high cholesterol, high inflammatory components. And in fact, it's predicted that 80% of all of this goes away if we change completely the way we live. That's how powerful lifestyle is. And it's because it affects every aspect of your health, the brain, the heart, and others. They're all affected, influenced by the same lifestyle. So I say to people, I don't care why you do it, just don't smoke. Because it doesn't matter what you do it because you're afraid of cancer, great. I know your heart will be better and your brain will be better. So you don't want to eat the food because you don't want to have all this unhealthy food because you don't like the way you look on the swimsuit. Great, do it because of that, because I know your heart and your brain will be fine. And there are people who say, I don't care the way I look on a swimsuit. I just want to make sure my brain say, great. Then, it's always the same answer. Eat healthy, exercise, deal with the stress, find the ways to fend, either buy out your neighbor or fend yourself from the stress inputs. But it always leads to kind of a similar answer for most of these major chronic conditions, because they're mostly the result in some way or another from the lifestyle we have in our society. Okay.
Dr. Lopez, I wanted
Thank
to,
you. Appreciate that. That's a kind comment. Yeah. Yes, somebody at home.
yeah, it's Karen, and I wanted to ask about that new PET scan that is developed there. There used to be something, or there's probably still is, live scan. There are companies that go around and offer to do a full body scan, and doctors generally discouraged it. They've said, I don't know, that it would give false information or alarm people needlessly or whatever. But this seems like it could do somewhat the same thing.
Worse, because it's so sensitive.
Uh-huh.
We're picking up all kinds of signals that we're scratching our heads about what to do with them. So yeah, it's a real problem. We need to deal with it on the research. When we do this research, we tell people they could be incidental findings. And one of the risks of doing the research is you can get anxious about them. It's part of full disclosure, right? So we help people in that conversation. We look at it, we come up with plans, we call your primary care doctor, we talk about whether you should do something about it now or just wait 3 months, like I mentioned earlier, and then repeat something and see. So we do walk the walk with people when that happens, but we see a lot of it. It's a part of reality of having more sensitive, better scans. Same problem we have when MRIs became really good. People want total body MRI, but wait, I'm going to find all these dings everywhere. What am I going to do with them? That's, I think, what you're alluding to. People do the same thing with scans. I can get a total body CAT scan and, get all this information to my doctor, my good doctor who's going to help me better. That's what the companies that put this out together tells you. The doctor receiving the report with 12 things that doesn't know what to do with them wasn't thinking that, you were doing them a favor, because if we don't have clear answers to you, that creates stress to you and to the doctor, because now what are we going to do with this? And together we now have to kind of hold hands and wait and see what happens in 6 months and do another scan or another test. So it does open the door for additional testing and worrying. So I tell people, we tell people that there are incidental findings and we will have to navigate them together when they come up. And most of the time we done just fine with it, by the way. we're doing a large heart failure study. The Mayo Clinic is working with us on it, and it includes an exercise test. And so they were in one of our steering committee meetings. They were saying it's very important that you check these tests for incidental findings. And they said the second patient they did at the Mayo Clinic, they weren't thinking or looking for ischemic heart disease or blocked arteries, but the person they thought they had heart failure. They put them to pedal on the bicycle, and the doctor was paying attention to the EKG, which, by the way, I do when I do these tests. I need to be in the room paying attention to it. And the doctor paid attention to the EKG and said, wait, slow down. That doesn't look so good. You feel okay? He said, yeah, I kind of feel okay. He said, yeah, but why don't we stop? And stop the test prematurely. Within 36 hours, that person was having bypass surgery because they had such a narrow artery that no one knew about it. That's an incidental finding that's beneficial to you. And that's the point. Some of these are beneficial to you. And we tell people that. We may pick up something early enough or before you have a symptom that could help your doctor. But we could also pick up things we don't know what to do with it. And so it has to be a very open conversation about, what do we think we do? How do we help? How does this better for you or not when we have those findings? So.
And what is the cost compared to that of an MRI? When they say it's like $3,000, or maybe it was a few years ago anyway. So what is the cost of this roughly, or is that going to be prohibitive?
For most of us, it's prohibited.
Uh-huh.
In the research space, it's really hard to answer the question, but I'll try to give you some perspective. The FDG costs anywhere between $150, just a tracer, the injection, costs between $150 and $600, depending which scenario you're in. The scan can cost anywhere between $1,000 and $4,000. And then we have another study, we're using a different tracer. That tracer costs $7,000, just an injection. So it varies about the scanner, the tracer you're going to do, and the radiologist is going to read it. All of those are independent costs of each other. And all of them may vary depending on what's been done. So, you could probably get a PET scan under $1,000 in a research protocol. I don't think you'll do that we'll find that in the clinical space, but it can range between $1,000 and $7,000 for one of these scans under a research protocol where it's been paid by a grant, usually. Usually that does not go to your pocket as a participant. Usually as a participant, you have no cost to get these. That's the other thing. You get these scans for free.
Yeah. Thank you.
Yeah, the cost of the tracer, depending who makes it and how hard it is to make. And so if there's only one company in the country that makes it and it's hard to make, you're paying $7,000. If it's something that is getting made in every corner and it's available everywhere, like FDG, then you pay $100, $200 for it because it's just readily available and everybody makes it. It's a clinical tracer, so it's available in every hospital. First, I'm sorry? They could be. So we look at the radiation exposure and we quantitate that and tell people this is more or less than flying on a plane, more or less than taking 2 X-rays a year, more or less than a regular CAT scan your doctor gets for, a cough. So we kind of give people some perspective about what these scans, how much more or less there is. And I'm quite excited that most of these scans that we do are no more than what you get on a regular scan from your doctor's office. And a lot of them are actually less than it would be. Even though we get a lot more information, radiation-wise is less.
It's more expensive tracers. Not only are you paying a bunch more money, but you're also putting yourself at more serious risk just to be.
Yeah, it's tracer dependent, but the couple tracers that we're working with, they're regular molecules that your body sees regularly. They just chemically, they just attach them to a tag that has the emission, the nuclear emission. And that usually in most of these, like FDG, it wears off within like 3 hours. So for about 3 to 4 hours, you have a slightly higher risk, a higher exposure than you would to the regular environment for that amount of radiation, which is small to start with, and time-wise is a small amount. Some of them wear off within 10 minutes. So it goes into your body. The picture has to occur so fast. You have to be laying on the scan, they inject and start a second after we inject, we start scanning because 10 minutes later it's gone. So, but most of them are chemicals that your body already knows how to handle. Like the other protocol we have is butanol, which is like ethanol. Ethanol is what's on your beer and your wine. And the same pathway that clears the alcohol from your body is the same pathway that clears the butanol, just a variation of ethanol. And so these are not rare chemicals or things that are very sophisticatedly been built that the body doesn't know what to do. Most of them, because it's physiological, most of this is physiological testing of your body, things your body already knows how to handle. And we just tag them to see where they go and how they get broken down. So, I'm losing sense of time. What's the time right now? Oh, I am needed back at the clinic, so I gotta go.
So your form's up.
Oh, yes, you'd be kind enough to fill out an evaluation. That's the only way the university knows that I was here and I was doing something. They think otherwise I'm playing hooky and having lunch